Good evening, everyone. I am glad to be here today to share with you a little bit of how to treat early malocclusion. When we are talking about early malocclusions, there is a lot of discussion if it is worth it to start treating early. One of the problems is that intending to treat a malocclusion is sometimes aiming to correct one problem and is not analyze what is happening with the patient, what all the problems and all the habits associated with the problem are. So today we are going to talk about a particular case, an anterior crossbite. An anterior crossbite is a very common situation in our office because the parents consult frequently about that. And in the following webinars that I am intending to do once a month, we are going to continue discussing different cases. But the most important part when we are intending to treat a malocclusion at an early age is to analyze what is happening and why that is happening. For example, if we have an anterior crossbite, we have to ask if the problem is in the mandible is growing too much, or is because the maxilla is not growing enough. Most of the people tend to think that the mandible is growing too much, but in most of the cases it's because the maxilla is retruded. And if we have a maxilla retruded, we have to think that the tongue cannot position on the maxilla. The tongue has to rest on the floor of the mouth. If the tongue is resting on the floor of the mouth, it's not stimulating the growth of the maxilla. So it's not as simple as correcting the position of the teeth, trying to bring the upper incisors in front of the lower incisors. It's understanding what is the problem and how we have to correct all the problems associated and that, let's say in this way, are behind the curtains causing the malocclusion, causing the anterior crossbite. So today, as I said before, we are going to analyze this case of the anterior crossbite. I'm going to do the presentation of the case. I'm going to analyze the case for you. I'm going to go over how I treated the case. And then at the end, you may see the treatment that we did, the case corrected, and you can have questions on this particular case or in cases similar to this. So if you have any question, please write the question on the chat, and after the presentation of the case, I'm going to answer all the questions. So let's have a look of the case. So let's review the case. We are going to review today a clinical case that came as an anterior crossbite. Anterior crossbite is a very common consult by the parents because they observe that the bite of the child is wrong, that something is not matching correctly in the mouth. And when we consider anterior crossbite, basically we are talking that the upper incisors are positioning behind the lower incisors. But it's not a matter of simply identifying that problem, but understanding the problem. For example, in this case, yes, we can see here that the upper incisors are in a wrong position, but we have to ask here why this is happening. And when we analyze in a sagittal direction an anterior crossbite, the lower incisors are positioning forward to the upper incisors. That may infer that the mandible is growing too much. But in many cases, when we analyze the problem closely, we can observe that is not a problem in the mandible. It is a problem in the maxilla, that the maxilla is retruded. So when we analyze the anterior crossbite, we analyze sagittally, but also we should analyze vertical. In this case, it's a sagittal problem because we have the maxilla positioning behind the mandible, but also the maxilla is coming in behind the mandible in a deep bite. So we also have a vertical problem. When we analyze the position of the maxilla, for example, in this case, we can see that the left side is higher than the lower side. The right side is at the line, and the left side is higher than the right side. That means that the maxilla coronally is in this direction. If we may go further and analyze a little bit more the function of this patient, most likely this patient may be chewing on the left side more than the right side. So when the patient is chewing, is pushing more the maxilla in this direction on the left side instead of pushing the maxilla on the right side. So the maxilla rotate more lower on the right side and going up on the left side. So if we do a full analysis of these patients and we see all the dimensions on the way that the craniofacial growth and development is happening in this patient, we can say that yes, he is an anterior crossbite. But if we see sagittally, the problem is that the maxilla is protruded, not that the mandible is protruded. And if we analyze transversally, we can see that the maxilla is narrow. At this moment, we see that the lateral incisors, the maxillary lateral incisors, are erupting and there is no space for them. They are rotated because there is not enough space for them. Actually, if we look at the mandible, it's a good development. Why? Because the tongue has been positioning all the time on the floor of the mouth. The tongue is not coming to the roof of the mouth, so it's not permitting a good development of the maxilla. Then, if we analyze vertically, we can see that this patient is a deep bite. The vertical dimension is reduced. So we need to reestablish that vertical dimension in this patient. The other problem that we have is that, as we mentioned before, the left side is higher than the right side of the maxilla. So it infers that the maxilla is rotating coronally towards the left side. And now, if we have a frontal view of the maxilla and the mandible, we can see that the midline of the maxilla is shifted to the left side. Most of the time we are talking about the midline on the mandible, but we need to observe also the midline on the maxilla. If you observe a little bit the face of this patient, you can see that the midline is deviating a little bit on the maxilla, but the chin is at the center on the midline. So most likely the rotation is on the maxilla towards the left and not on the mandible. And we need to consider another dimension. And the other dimension, the sixth dimension, is the time. If you evaluate, this patient has been working, has been functioning over 8 years in this situation, because now he's 8 years old. So over these 8 years, something may happen in the function that start moving the craniofacial growth and development in a wrong direction. If we intend to correct only the anterior crossbite without considering the transverse problem, without considering the vertical problem, without considering the coronal problem, and the frontal problem. And we try just to push the maxilla forward to bring that to a better sagittal relationship. Or even worse, if we try to push the mandible backward to match with the maxilla, obviously the force of the tongue is going to push this mandible to this position again, and we will have a high risk of relapse in this case. So if we start thinking about this case, to move the maxilla forward, we need to permit this maxilla to come forward. To produce that, the priority here is to increase the vertical dimension. So in that way, the maxilla can come forward without the interference of the mandible in front of it. And then when we have the maxilla free to move forward, then we can stimulate with any kind of appliance to move the maxilla forward. But at the same time, we need to produce more transverse development that the tongue can move from the floor of the mouth to the roof of the mouth. And in that way, the tongue may help us to produce a better transverse development of the maxilla, and the tongue can start functioning from the roof of the mouth during swallowing. And you may remember that we are swallowing approximately 2,000 times per day. In other words, we are swallowing approximately twice every minute. So if we produce a good function of the tongue, we are going to develop a physiological force on the maxillary bone, and we are going to get a good development of the maxilla. And at the same time, we have to think about the rotation of the maxilla towards the left side. The left side is higher, so we need to change the force during mastication that is pushing this maxilla upward, and is permitting this side of the maxilla to rotate downward. So if that is produced because the patient is masticating more on this side, I need to switch the side of mastication to the other side. So in that way, I can invert. Instead of pushing this upward, I'm going to permit this to come downward. And instead of permitting this to come downward, I'm going to create a force going upward here. And with the tongue sitting on the palate and the maxilla free, I'm going to permit a rotation of the maxilla towards the right side so the midline can be corrected and the maxilla can be centered in a good relationship with the mandible. So as we mentioned, we need to develop the maxilla, because if we analyze the panoramic, we can see that in the mandible we have a good development. We can see that the premolars and the canines are developing, and the eruption pathway is in a good direction. They are in a vertical position, coming in a good direction to erupt into the mouth. But if we move to the maxilla, we can see that the premolars are tipped and the canines are very tipped towards the lateral incisors. In this case, the crown of the canine is not overlapping the roof of the lateral, which gives us a good prognosis that most likely if we produce a little bit of development in the maxilla, the canines are going to come in the mouth with no problem. So we need to keep that in mind. So the first step, as we mentioned before, we increase the vertical dimension. If we see, we start analyzing the case in March of 2016, and now we are in June of 2016. At this moment, we had increased the vertical dimension with a technique that I don't have the time today to elaborate on it, that I use in many of these cases, that is called the planus direct trax. And we are combining that technique with a myofunctional appliance that permit the maxilla, guide the maxilla to come forward. In that way, we have now an edge-to-edge position, and we are starting to have a little bit of overjet after 2 months of treatment. If we continue treating the case with these techniques together with myofunctional therapy, because what happened at this moment, we need to use myofunctional therapy to educate the tongue to sit on the roof of the mouth. Myofunctional therapy exercises combined with the appliances is an excellent approach, because at the same time that we are stimulating a good development of the maxilla and maintaining a good development of the mandible, we are improving the functions. When I talk about the functions, we are educating these patients to be a nasal breather and to position the tongue on the roof of the mouth to do a correct swallowing and to maintain a good lip seal with a good posture of the head on the neck and with the body. So in that way, the myofunctional therapy is going to work in improving all the functions in these patients. In the meantime, the techniques are correcting all the problems that we have in craniofacial growth and development. If we continue treating that patient in that way, another of the exercises that we include in this patient is changing the side of mastication. When we were elaborating on the problem, we saw that the left side was higher than the right side. Now you can see that the patient is switching the mastication to the right side. Now the lower side, the left side is slightly lower than the right side. So at this moment, we have to educate the patient and teach him to chew bilaterally. Whenever he is chewing, he should chew approximately 5 times on the right side and approximately 5 times on the left side. In that way, we create an equilibrium during the mastications, that the force of the mastication are delivering a force and is creating a strain on the maxilla similar on both sides. So here we continue working with the planar direct tracks, the myofunctional appliances, and the myofunctional therapy. And you can see that now we are getting a better transverse development of the maxilla. So if we analyze the case at this time, in June 2016, approximately 3 months after we started the treatment, we can see that the retruded maxilla has improved. The maxilla has moved forward, but still we need to move a little bit more to create a better relationship with the mandible in a sagittal perspective. Then, if we analyze the transversal of the maxilla, we can see that now we are getting more development on the maxilla, and now we have more room for the teeth. Still, we need to improve a bit more. Then when we analyze the vertical, we have now a better vertical dimension that is starting to become to a normal situation. So the vertical has improved as well. The coronal rotation, as we showed before, the left side and the right side are in a better level now. So they are becoming better. And still, we need to work on the frontal rotation of the maxilla. Because now that the maxilla is free, the maxilla can start developing similar on both sides. And we can create a rotation towards the right on the frontal side. And still, we are working in the timeline that the patient is still an 8 years old boy. So moving forward, in September that year, 2016, we have that situation now. We have a better overbite, a better overjet, and the sagittal relationship has improved. The transverse relationship has improved, the vertical has improved, and you can see now that the superior and inferior midlines are in the same line. So the frontal rotation that the maxilla was going towards the left now is coming back to the right, and we have the midlines in a similar relationship, in a good relationship between the upper and the lower. And when we see the level of the maxilla, now we can see that the left side that was higher than the right side, now they are at the same level. So everything continues improving, and the patient is developing transversally. Now the lateral incisors are in a good position. There is a good alignment, and we didn't have any problem on the lower arch. So we continue observing the upper dental arch for all the changes. So the sagittal, the retruded maxilla continue improving. The transversal, we have a good transverse development now. It has improved. The vertical continue improving. The coronal is improved. I will say at this moment is corrected. And the frontal has improved, and at this moment is corrected. And still, the patient is 8 years old. So at this moment, we have a good response in this patient, and the patient is following the instructions, doing all the myofunctional exercises as instructed, using all the techniques that we are using with him as instructed. So we have a very cooperative patient that we don't have any issue with him. We came to October 1 year later in 2017, and we have this situation now. We have a good sagittal relationship, so we have an overjet of approximately 1 to 2 millimeters, which is the ideal for this patient at his age. We have approximately a 20% overbite, that is the ideal for that patient at that time. We have a good class 1 canine relationship, where the lower canine is in front of the upper canine, and we have a good posture. Now we have a good nasal breather. The tongue is still practicing to sit on the roof of the mouth, and we have a good transverse development with no problems in this patient. So if we analyze again on the 6 dimensions, this patient has now a correct position between the maxilla and the mandible. We had before, approximately a year and a half before, we have a retruded maxilla, now is corrected. We had a transversal problem that we have a narrow maxilla, now is corrected. Even we have a little bit of a space on the midline for the eruption of the canines. We have now corrected the deep bite that we had before. We have a correct vertical dimension for his age. The coronal was higher on the left side and lower on the right side. Now that is corrected, and the occlusal plane is in a good level. And now the midlines are in a good relationship. So all the problems that we have in craniofacial growth and development were corrected. Plus, we have a better nasal breathing, we have a better swallowing with the tongue sitting on the roof of the mouth whenever the patient is doing a swallowing. And this time that we had before 8 years, now in a year and a half, we reestablished all the functions and we corrected all the problems that we observed on the craniofacial growth and development. Not simply pushing the teeth to the front, the upper teeth to the front, permitting a good development of the maxilla in all the dimensions in about a year and a half, because if you remember, we started this case in March 2016, now we are in October 2017. All the problems that we observed in the 5 dimensions that were affecting the craniofacial growth and development were corrected, and that function that was happening over about 8 years, now we spend about a year and a half to correct all the functions. So all these together are going to produce a more stable result. So from now on, we are going to observe the patients. So we start observing this patient about every 3 months at the beginning, then we start observing him every 6 months. And if you observe In March 2016, we were in this situation. In June 2016, we had corrected the sagittal and the vertical problem, and October 2017, we had corrected the sagittal, the vertical, the transversal, the coronal, and the frontal problem. So, evaluating the patient and treating the patients in the 5 dimension is going to produce better results and more stable results, together with the function. If we don't correct the position of the tongue that we have at this moment, that was most of the time on the floor of the mouth, bringing it to the roof of the mouth, if we don't correct the mouth breathing that this patient had at that moment, if we don't correct the incorrect swallowing that that patient had at that moment, we cannot produce a stable result. So, if we follow that patient 1 year later, from October 2017 to October 2018, now we have even a better situation. Everything continued developing in a normal direction, sagittally, vertically, transversally, coronally, and frontally. So everything continued functioning in the correct way. You can see that now we have all the permanent dentitions. As we saw in the panoramic at the beginning, the canines were tipped against the lateral incisors. Now they are in a correct position in the mouth. We have a good shape of the upper dental arch. We have a good shape of the lower dental arch. We have a good overbite, a good overjet, a good relationship between the maxilla and the mandible, and all those oral functions are in a physiological pattern. So basically with this patient, we need just to follow and observe. And in June 2019, you can see that the patient continued developing correctly, and we don't expect any relapse because now all the functions are in a physiological way, in a proper way. The tongue is sitting on the roof of the mouth, so is stimulating a correct development of the maxilla that is going to permit a correct setting of the mandible in a good relationship with the maxilla. It's going to maintain a good position of all the dental arches in a good relationship between the upper and the lower. So we don't expect a relapse in this patient. Then the last time that we saw him was last December, and we can see that everything continues stable, and the patient has been now more than 2 years with no retention. Basically, the best retention is the muscles. Every muscle around the mouth, every muscle of the tongue is functioning in a physiological way, maintaining a good growth and development of this patient. This patient is now 11 years old, and everything continues developing. In the future, most likely, he's not going to need any further treatment. So the idea is to start early but doing a complete diagnosis. It's not only seeing that we have an anterior crossbite and we have to move the teeth, the upper teeth to the front, or push the mandible backward. We have to analyze everything that is happening in the patient. We have to analyze the patient in the 6 dimensions. So we need to think what is happening sagittally. We need to think what is happening vertically. We need to think what is happening transversally, coronally, frontally, and how long that patient has had an incorrect function. Once we correct all the 6 dimensions and we put the patient to maintain a correct oral function associated with a correct nasal breathing, we are going to produce stable results that are going to last longer or probably forever. So there are 2 courses that we will have here in Toronto in the near future. The first one is called the Wholebody Connection. We are going to have the pleasure to have Professor Mariano Rocavallo, who is one of the leaders in the world in the relationship between the mandible, the TMJ, the cervical spine, and the hyoid bone. So Professor Mariano Rocabado is going to be with us in May 2nd and 3rd, and he is going to be teaching us about how to correct the problems that may be associated with the cervical spine, the TMJ, and the position of the hyoid bone. We will have also together with us Dr. Jim Bronson, that he's gonna talk with us how he used the ALF to improve all these problems. And we'll have also Fabiola Nosa talking about myofunctional therapy, and also Louise Lane, that she's gonna talk with us about all the connections of the cranial nerves and how we can stimulate them better to produce a better result in our patients. So the five of us are we going to be sharing our experience on how to connect the whole body to produce a better result in our patient. If you want to register or get more information about this course, you can go to kidsmalocclusions.com, our webpage, and you can have more information about. This is happening on May 2nd and 3rd this year here in Toronto. And then we have also the Airway Orthodontics Mini Residency. My Airway Orthodontics Mini Residency is 4 modules. The first one is starting by the end of May this year, May 30 and 31st. In this model, I'm gonna be teaching you about craniofacial growth and development and how to use the planus direct tracks to improve the vertical dimension and the relationship between the maxilla and the mandible. Then the second model is going to happen in June 27-28, that we were going to be discussing how to combine all these techniques, particularly using the ALF appliance. And then we will meet again in September 26 and 27, where I'm going to be integrating all the myofunctional techniques that I use to improve all the results in the patient. And also in the module 4 in October 24 and 25, I will also explain how I do palatal expansion with my own palatal expander that permits a correct function on the tongue. In the meantime, we are producing a palatal expansion, and also how to use a maxillary protractor in the mouth, and also how to use a maxillary protractor in the mouth, not an extraoral appliance, for cases that you have a severe retruded maxilla and they don't respond very easy to myofunctional techniques. Together in all the mini residency, Fabiola Nosa is going to be teaching your staff, so you are welcome to bring your staff also, that they can be trained in the myofunctional therapy that we do and all the protocols that we follow specifically for each case, that you can individualize for your patient when you are producing a treatment to correct a myofunctional problem, to correct a malocclusion, and to correct a sleep and breathing disorder all together. So if you want more information about this, in the same web page that we were mentioning before, kidsmalocclusions.com, you can get the information, you can get the registration site for you as a doctor, or you want to register your staff to be trained in myofunctional therapy, and to get all the information so you can start producing results, stable results, more functional results in your patients when you are treating early a child. For example, in the case that we discussed today as an anterior crossbite. Next time, we are going to discuss also about anterior crossbite, but in a case that we have an open bite. So let's see how many questions we have at this moment, and I will try to respond them as many as I can. As you may understand, it's difficult for me to respond everything in the timeline that we have today, But if you want to learn more about this, you are more than welcome to come to Toronto and do our mini residency, and you will have all the information, and I will have the opportunity to clarify all the questions for you, and also to follow cases with you that you can start treating some cases with my guidance. Thank you very much. So let's see all the questions that we have now. I hope you understand that managing a case like this involves to treat all the problems associated with the malocclusions. There was a question if there was any problem with tethered oral tissues, and the tongue learned how to sit on the floor of the mouth because the maxilla was too small. So the tongue became lazy, staying all the time on the floor of the mouth. Once we developed the maxilla and through the myofunctional therapy, we re-educate the tongue, and the position of the tongue came to the roof of the mouth where the tongue should be. Not only is important for the function at swallowing and talking, all the oral functions, but the tongue is going to maintain the normal development of the maxilla in the future, and is going to prevent a relapse in the future. So that's why it's important to have the myofunctional therapy in conjunction with all the appliances to obtain these results, because we need to identify all the problems that we had at that moment, in this case when the child was 8 years old when we saw him, and to correct all the problems. This is going to produce a better result and a more stable result. So I expect that you find this information helpful and interesting for you. My goal is to continue doing more webinars, at least once a month, presenting different cases and sharing with you my experience and how I treat them. The video is going to stay in Facebook, so you can share the video with your friends, with your colleagues, and in that way we can help other kids to have an early intervention and to prevent problems that may be very complicated in the future. Thank you very much for your attention, and I hope to see you in about a month. We are going to publicize when the next webinar is going to happen in February, and I will hope to see you then. Have a good night and all the best for everyone. Thank you.